Welcome back to Let's Talk Podcast Series, heute auf Deutsch. Und ich freue mich ganz besonders, Herrn Dr. Detlef Loppow zu begrüßen von der Martiniklinik.
Ja, vielen Dank. Ich freue mich auch, Frau Völter, und ich habe mich auf Englisch eingestellt.
Wir können das auch auf Englisch machen, ganz wie
As
Sie
you like it. So for me, it will be no difference.
Well, perfect. So, dear listeners, 180 degrees, we'll do it in English. And I think it will be fine with everybody. So, my name is Verena Wolter. I'm the CEO and founder of 5P Healthcare Solutions, a consulting firm that helps players of the 5P ecosystem deliver and transform towards value-based healthcare, which we will talk about today. And what is very important, we will talk about what it does rather than name dropping and buzzwords, which it is a little bit. So without further ado, Detlef, I know we always start with that 10,000 feet bird's view question. What does value mean for you in healthcare? You know, as we talk about patients and value-based healthcare. So anything that spontaneously comes to your mind from a big picture perspective?
Well, I think the main explanation was done by Michael Porter, who just said it's achieving the biggest value will be achieved if a hospital is able to deliver the best possible outcomes that matter to patients by the lowest costs to achieve this treatment. So I think this is the key, and this is mainly what we've done here in the Martiniklinik. It's a specialization. It's the high volume surgeons having a high volume specialized clinic, having the high experience and focus on limiting the costs, and always have in mind patients first. So what can we do better for our patients in terms of better outcomes for them?
Excellent. So let's dissect that a little bit. And the keywords are all there. And we'll continue along what you said, outcomes that matter. I liked a lot. We will talk on a tangent a little bit about cost, but I think because it's part of the equation and it's in the denominator of the equation of value. So let's talk first a little bit around the focus on the outcomes. And you already started talking a little bit about the volume, high volume surgeons. So maybe we get to that after. I really want to ask you around what you also said, patients first. So this is kind of another buzzword right now. If you open social media or whatnot, it's like patient centricity. It's like, great, sounds super. But how do you do that practically, for example, at the Martiniklinik? How do you live that word?
Well, let me also start on a higher level.
Yeah.
Usually, if a patient is treated in a hospital and he leaves the hospital, the surgeon or whatever kind of physician has treated the patient does not know what happened to him afterwards. Yeah, nobody knows whether you've done a good job with your patient or not, and then we have different quality measures. Yeah. First of all, the hospital started to measure patient experience measures. Yeah. So was the nutrition good? Was it clean? Have I been well informed? Would you recommend the hospital to friends or family? And so this is the easy way. The other way are such surrogate markers as the structure criteria. Yeah, it's like if I would ask you, do you have a car? You would for sure say, yes, I have a car. Do you have a garage? Yes, I have a garage. Do you have a car wash? No. So what's the right conclusion is you can only be an average driver. Yeah, and we are confronted with a lot of these surrogate markers for estimating the quality that you can really deliver. The key is at the end that you ask the patient what is important from his point of view. If you would enter an airplane to fly to somewhere else, it would for sure not be the question whether you have survived the flight or not. Yeah, and we're still measuring mortality rates. So the key is, as a hospital, you've done the right job if from the unfulfilled wish for a child until the palliative situation. Every customer would say, I've been in the right place at the right time, and then you've done the right job. So for us, treating patients with prostate cancer, it's very easy. The cancer patients would get rid of their cancer. They want to be able to have sexual intercourse after surgery, and they don't want to pee in their pants after surgery. So it's very easy and quite objectively measurable variables.
Thank you for those real life examples of a car and a plane that we all can relate to, and it makes it really practical. I love that. And maybe for those who don't know yet, the Martiniklinik is a specialized clinic on treating patients with prostate cancer and have been doing so for close to 2 decades, if not longer. They're one of the lighthouse examples. When I get the question every day, Detlef, well, tell me, does this really work, value-based healthcare? I'm like, okay, now I can say, listen to the podcast with Dr. Loppow, and yes, it does. So breaking it down, and particularly as an oncologist, where yes, the gold star is survival for the patients. You want to get rid of your cancer, you want to live. Okay, I love that. You want to survive the flight with your plane. When you go to Mallorca, you want to arrive lively. So can you tell us a little bit more before we go to the quality surrogate markers and talk more about the physician, like one layer down on the patient experience side? And I want to, help you and the audience understand. So getting rid of the prostate cancer, operate on the prostate, but like what is really important to patients. And I think you have heard it, that the continence, urine continence is important, erectile dysfunction is important. Can you help us understand what's so special for patients in the Martiniklinik compared to an average, what we can read in terms of maybe percentages in the literature? Why is it different?
Well, first of all, to give you an example about the German market, in 2019, there were 414 hospitals who performed radical prostatectomies. There are only 16 hospitals who did more than 350 cases. And on the other end, there are 247 hospitals that had less than 50 cases. So you need some experience as a surgeon, and as Andrew Vickers has published in 2007 for the open radical prostatectomy, a surgeon needs about 350 cases experience until he is capable to treat 90% of his patients in a way that they don't suffer for a recidive within the first 5 years. So you need high volume, very experienced surgeons. And what we can say from our experience is that even between the 4,000 surgery and the 5,000, there's still an increase in outcome, in quality, in certain parameters. And this is, I think this is true for every treatment, for the dentist, whatever.
Yeah. Maybe you can help us understand practically how this works, because you do ask the patient in the beginning what is important to you, and then you ask them regularly, right? After the surgery, 6 months afterwards, lifelong. Tell us a little bit very practically. If we use your system.
Yeah, we use we've implemented with the ICHOM organization the standard set for localized prostate cancer treatment, and in this context, we have defined which variable has to be measured at which time point. And so for localized prostate cancer, you do this EPIC 26 questionnaire before treatment, and then 7 days after surgery, we ask for how we call it, the urinary early continency. Then half a year, we ask for complications, very detailed. In the beginning, we asked quite open, did you suffer for any complications? And most of the patients said no. And then we started asking more precise, do you have how you call it, an infection of the urethral tract? the bladder, whatever, and then we get a higher complication rate because we ask more precise and we get better answers from our patients.
And I think it's fair to say that patients treated at the Martiniklinik during their entire journey, because as you said, it's not only during the hospital stay, it's really the entire journey. And I think it's key what you said in the beginning. It's like what actually happens when patients fall off the cliff once they leave the hospital. It's a huge gap, and there's a lot of things that go wrong at that transition, at that intersection. Fair to say that I think you have twice as good numbers in terms of urinary continence and sexual function by the way you do it holistically through high volume surgeons, plus really focusing on patient experience and involving the patient in the care.
Yeah, it's very difficult because there's not a lot of data available. So in 2012, so it's already 13 years ago or 12 years ago, one of the health plans just made a survey in their patients, and compared to this, we know that the continency rate in Germany can be expected 56.7% overall, and in our hospital it's far above 90%. Yeah, and the severe urinary dysfunction is much lower in the Martiniklinik. And
this is kind of on average 5 patients out of 10 will have continence problems, and in your statistics it would be 1 out of 10.
Yeah.
So patients are fine. Yeah. And there are 2 more elements I was curious to ask you questions about. One is what you have, the flat hierarchy internally of your staff. Yeah. So the care coordination, maybe we can talk about that a little bit. And then I want to afterwards dive into more the doctors part of it. But tell us a little bit like this holistic approach, like, everybody auf Augenhöhe, no? Like, how does this work practically in your
hospital? I mean, it's very simple. Usually in Germany, you have this strong hierarchic structure. You have the head of the department and the Chefarzt. Yeah, and if you start to measure quality outcomes, then you see if you train a surgeon, your overall quality will increase. And when he is finally trained, he will leave the hospital to become a head of urological department anywhere else. So if you want to retain the once trained surgeons in your hospital, you have to find a structure that allows different heads working together in a kind of faculty. And that's what Hartwig Huland, our senior and founder, has implemented in the Martiniklinik. So we have a faculty of 9 surgeons at the moment, and they're on one level, equally ranked, equally paid, and this is a very
strong American group. Audience. This would be like division chiefs, so they are not only 9 surgeons. I'm just reassuring everybody.
No, only.
But there are 9 division heads. Chiefs. Yes.
Yeah. And everybody, I always say, every king needs his own kingdom. So everyone, besides being specialized as a urologist, besides having subspecialized on treating only prostate cancer, everybody has his own topic where he's the unquestioned king of his kingdom. For all the imaging topics, for the treatment of the advanced diseases, for robotic surgery, for the scientific aspects of our work here. So everybody has his own super specialization.
Yeah.
And
so I think it's very clear. So there is a sense of empowerment, of democratic leadership, and of clear governance and roles and responsibilities. And I think there's one thing, you do have queens as well, right? You don't only have
we also have yeah, for sure. For sure. Yeah, we have also physicians who work
So that was
female physicians. So yeah.
Yeah, and I think in terms of that eye-to-eye perspective, that is very important in the doctor-patient relationship, but it's also within the provider community about their experience and their satisfaction, right? That you're saying, and that makes the retention. So you don't lose those super experienced doctors because they're actually very happy where they are, and you do this through.
Yeah, exactly. The whole organization is optimized, first of all, for the best patient treatment, but on the other hand, also for the different subgroups of employees here. So for the doctor, for the administrative staff, for the nurses, the OR nurses, and so on and so on. So we try to take all the parts that are not necessarily done by the physicians, should not be done by the physicians. Yeah, and so we I think that compared to being a head in a department in the University Medical Center, it's much better to work in such a specialized center where you have also experts for all the administrative things that usually would be your task.
So thanks for mentioning this, because I think that was one of the points in terms of the care coordination and the take off all the administrative bureaucratic work to specialized roles and professions, be it a care coordinator, case manager, whatever the term for it is. But I think the principle of shaving off the admin work of the doctors is actually probably a big contributor to their satisfaction.
Yeah.
So.
Yeah, and I mean the overall organization, we try for a surgeon to have 3 days in the OR, 1 day serving in the outpatient clinic, and 1 day for research. So that's the big plan that we have.
Excellent. So talking about the doctors a little bit, and I think we spoke about this last year. So one key thing is the transparency of the results. So, every single patient will be reported, discussed in debriefing meetings, what complications happened, what not. So it is a very vulnerable environment. And I hear often from hospitals or who approach me and say, oh, Verena, you and 5P, can you help us with the transformation? But our doctors are really resistant and they're really afraid because of the blame shaming. And I think it's a real concern and a real anxiety. And I think almost to me, it's the biggest thing we can learn from you. How have you, and of course it takes time, but tell us how this has been changing in the culture at the Martiniklinik.
I think our big advantage is that we have grown with this culture. Yeah, it's not that we have to implement another culture. So when the first specialization took place in the University Medical Center before the foundation of the Martiniklinik, there were urologists who just shared Hartwig Huland's department for receiving a good education in treating prostate cancer patients. And then they started to collect data. So I mean, we started to collect data in 1992. Yeah, and the Martiniklinik was founded in 2004. So the history of the Martiniklinik started long before it was founded. And the idea of collecting the data in the first years was just for research purposes. And then everybody recognized that this data source is also very important for quality control. And then we developed this benchmarking every half year. Well, only in the group of the surgeons, data is presented about the outcomes that the single physician has achieved in his patients with a clear name, and it's about 60 charts. And you for sure you need an atmosphere without any finger pointing, and everybody has to share this idea of let's say starting the day with the question, what can I do better for my patients today, and going to bed with the same question. And then you see the distribution, you see a comparison to the previous period. There are some alterations. It's very motivating for the less experienced surgeons because they see that they come closer and closer to the results of the most experienced ones. And if there's a deviation, yeah, and somebody is worse because he had some trouble at home with his wife or whatever, then you can easily say, well, okay, just show that you still stick to the surgical approach everybody has committed to use. But what's more interesting is what happens if somebody is better than the others. Yeah, we had it once, and and first of all, the senior said, "Well, it's our young colleague. He has all the easy patients." And then the statisticians said, no, he has the same distribution of easy and intermediate and more difficult cases as everybody. And then the senior went to the OR to see what this young surgeon does differently than him and why he's better, yeah, in terms of the results. And it was a simple anatomical thing that this guy did differently. And then the senior adapted his technique, and then all the other surgeons, and therefore the early continency was increased dramatically in all our patients.
It's an amazing functioning of constant, continuous best practice sharing. And what I want to point out to the audience also things you said on the sideline. So we already spoke about the administrative, new roles and investment in new of these professions in the hospital. But you also said, like, there's actually a statistician that sits every 6 months and that prepares those slides and those analytics. So that's an extra resource also that is well invested, expertise and time and money to enable and be a facilitator of that learning culture to occur, and then really kind of do something differently with and for the patient, which is, so it's called nichts kommt von nichts. No, it's like you do have to invest in certain new ways and new jobs to take off things.
Yeah, this invest really pays off. Yeah, I think we have 6 employees just working in this outcome study group and in the IT department. And it's I mean, if you can optimize your IT system in a way that if the surgeon has finished the surgery, if he has just called the wife of the patient out of the OR theater, then he just walks to the documentation booth and just does 3 to 5 small changes, and the OR report is ready. So he can just change his clothes, gets the printed OR report, can sign it, and is done. I mean, how many time do you spend usually waiting for the surgeon to finish the OR report? Yeah.
Well, we'll do something innovative here. So whoever is listening and working in surgical departments, send us your number of, you can do it anonymously, of your statistics of how long it takes for an OR report to be issued and sent out. So it's going to be hard to beat you guys. Unfortunately, this is always the scary moment here. I'm looking at time and we're about up with our time. But the one thing that I wanted to ask you, what you could share with something in another hospital, maybe another specialty, and who says, oh my God, this sounds so great. And I want to start somewhere, but I'm so impressed and feel overwhelmed by where to start. And I think you already gave a little bit of a hint with 1992, you just started collecting data. And I think that is something anybody can start doing tomorrow almost. But what is a tip and trick you would practically recommend to somebody who says, I want to try this out?
I would say the most important thing is start with the right mindset, build up the right culture, collect the right colleagues, employees who share these values, and who are really, I would say, what really makes us a group here is that everybody is crazy about treating prostate cancer patients. Yeah, so if you're really an enthusiast to do a certain treatment, just go for it. collect the right nurses, the right administrative staff, the right CEO, that you really work together in one direction and give yourself enough time. So expecting a return on investment within 3 or 5 years will not work, because you need time, you need to make your own experiences, and it takes some time. And I'm happy I joined Martiniklinik. I say it's 8 years after the beginning. So
very nice concluding words. Thank you, Detlef Loppow.
You're welcome, Verena. Thanks a lot.